Today we shall be talking about management of open compound fracture. The fracture which communicates with external environment due to break in soft tissue cover is known as open fracture. Open fracture is an orthopedic emergency. Open fracture classification, which is given by Gostillo and Anderson. It is of three types: type A, type 1, type 2 and type 3. In type 3 it has type 3A, 3B and 3C. Type 1 is in skin wound. Seeing the skin wound size, type 1 is less than 1 centimeter and type 2 is more than 1 centimeter. And type 3A is usually more than 10 centimeter, 3A, 3B, 3C. Both are more than 10 centimeter long, more than 10 centimeter. More than 10 centimeter long, more than 10 centimeter long. Level of contamination. Type 1 is clean wound, type 2 is moderately contaminated and type 3A is highly contaminated, 3B is also highly contaminated and 3C is also highly contaminated. Energy of trauma. For type 1 there is low energy fracture, for type 2 low to high energy trauma, and type 3 A, B, C high energy fracture pattern. For the soft tissue injury, in type A there is minimal soft tissue injury, in type 2 there is moderate some muscle damage, in type 3A there is severe soft tissue injury with crossing and extensive soft tissue laceration, segmental fracture and gunshot injuries. In type 3B there is severe loss of soft tissue cover, requires flap coverage. In 3B requires flap coverage. In 3C there is severe loss of soft tissue cover. In type 3C there is neurovascular arterial injury requiring repair, C and circulation damage, injury to the circulation, arterial injury in the C. Type 3C, bone injury. In type 1A, simple minimal comminution, moderate comminution, and in type 3A, usually comminuted but soft tissue coverage of bone possible. Soft tissue coverage of the bone is possible. In type 3, bone coverage is poor. Periosteal, there is periosteal striping and moderate to severe comminution. In type 3CA, there is bone coverage poor, moderate to severe comminution. In management of open compound fracture, our principle is to convert the open fracture into the closed fracture by meticulous wound care. For phase 1. Phase 1, emergency care. It is at the site of the accident and in the emergency department. At the site of the accident, we do general assessment of ABC, airway, breathing, circulation. And if the wound is bleeding, it is stopped by pressure and packing with a clean cloth. If the wound is dirty, then it is washed with tap water and covered. Fracture is splinted. In the emergency department, we look for the neurovascular injury, and for the wound care, wound is washed and covered with sterile dressing. Then we do splinters of the fracture, then tetanus toxoid prophylaxis, parenteral analgesics is given. We do X-ray to evaluate fracture and assessment to grade the open fracture, radiological and clinical, Gostillo and Anderson classification. Then we give antibiotic. If the fracture is of type 1 and 2, then first generation cephalosporin is given, and if the fracture is of type 3, then first generation cephalosporin plus aminoglycoside is given. After emergency care, phase 2, we perform the definitive care, the care of the wound care, irrigation and debridement is done. After that, wound closure is done. Adequate irrigation and debridement is done. Excision of the dead and deadly tissue and removal of the devitalized tissue and foreign bodies. Wound cleansing by normal saline, then nerve and tendon repair. Wound closure. Plan of wound closure in open fracture. After the wound is debrided, if there is a small puncture wound, then we leave it as it is. If the wound is clean and lacerated, then we do primary closure only when debrided within 6 to 8 hours. And if there is doubtful of cleanliness of the wound, then we observe for 2 to 3 days And if there is no infection, then we do delayed primary closure, and if there is infection, we do secondary closure. And if the wound is infected, then healing is done by secondary intention. Now, if there is fracture, for the fracture management, non-operative methods give good result, and after healing of the wound, we do operative procedure if it is required, and if there is extensive soft tissue damage, then external fixator is used. After emergency care, definitive care, there is phase 3, rehabilitation, in which exercises is performed during immobilization and after removal of immobilization, and gradual weight bearing is done, and gait training is given, and muscle re-education is given. This is all about management of open compound fracture. Notes are available in the Telegram and the links are given in the description. Thank you.